Hi, I'm Earl Silverman, editor-in-chief of the Journal of Rheumatology. And for the month of June 2021, the article I've decided to pick for my interview is entitled Relationship Between Fatigue and ACR Response in Patients with Psoriatic Arthritis Treated with Tumor Necrosis Inhibitor Therapy, a population-based cohort study, and is by Jørgensen and colleagues from the University of Copenhagen, Denmark, University of Washington, and Stanford University in the USA, and Aalborg University in Denmark. This paper is now available on the journal's website at jroom.org for your viewing pleasure. Today, I'm pleased to be speaking to Dr. Lars Erik Kristensen, who's a senior author of the paper. Lars Erik, I want to thank you for taking the time to speak to me and our listeners about your interesting article regarding the association of fatigue and ACR response in patients with psoriatic arthritis treated with anti-TNF agents.
Thank you, Earl. It's good to be here.
Thank you, and hope everything's good in Denmark and that Denmark is doing well in the pandemic. So could you please highlight the important findings of your article?
Yeah, we went about to conduct this study first because we know from various sources, and it's been replicated, that fatigue is one of the main issues if we ask patients what's bothered them the most. So it's certainly an element of disease or symptom to look for. So that was the main driver. And then we wanted to see in this nationwide cohort of Danish patients how they behaved after we initiated an effective biologic treatment. And two things were actually quite a surprise to us. One thing was that we saw that, of course, we could diminish fatigue, but there was quite residual fatigue even after effective treatment. So it still remained a problem after we initiated effective treatment. That was one thing. And the other thing we found out was that, of course, it's correlated to our classical outcomes, our classical ACR, joint outcomes, responses, but it's not that correlated. When we looked at the kappa statistics and so on, it was only low to moderate in different patient groups. So it seems like it's more or less an entity in itself that co-lineates with inflammation and our classical joint outcomes, but we have to regard it as its own entity. That came as a surprise to us.
Yes, certainly, but very interesting nevertheless, and very important. Your study uses the DanBio cohort. Can you just briefly describe the cohort to the audience?
Yeah. The DanBio registry is more than 20 years old, and it was initiated in Copenhagen by Merete Hetland, a good colleague of mine in Denmark, at that time inspired by the South Swedish arthritis cohort. And here they systematically and nationwide started to include all patients starting off on biologics with chronic arthritis. Then down the road, they even included patients with non-biologics that starts as CSD-MART. So we have good coverage, and then we have the social security number in Denmark that we can link to other registries, which we actually also did in this article. So we can link to outpatient registries, we can link to in-hospital registries, cancer registries, and so on, because we have the common unifying social security number in Denmark. That's a great strength. So it's a well-renommed, a robust bio registry that we can expand or enrich with other types of data, and it's Danish national, so it's nationwide in Denmark.
I think that's great. I think every country needs that and needs to completely cooperate together. So in the article, it stated that you had 1,750 patients with psoriatic arthritis treated with anti-TNF in the cohort. Only 880 had what was described as useful data on fatigue. Were there any important differences between these 880 patients and the 870 patients that were not part of that?
We did a dropout analysis of the patients that didn't report fatigue, and we didn't find any systematic trends there. So you could imputate. We decided not to do it, but you could do that. So it's representative of the entire cohort, the ones we got the fatigue data from.
Okay. And I just want to make it clear that we're talking about patients who not that they didn't necessarily have fatigue, they just didn't comment on it. Correct?
Exactly. It was missing data.
Yeah. Okay. So I'm interested, you divided your cohort into two groups rather than quartiles, tertiles, et cetera, et cetera. What was the rationale for this?
Again, that's a good point. We there's no clear cut point for when do you have low or moderate or high fatigue. So we decided to make it data driven. And when we so that's the reason why we split on the median. And when we extrapolate the exact median of the cohort to other data sources from other chronic diseases and so on, we can see that actual level scored on a VAS scale, which is our outcome measure here for fatigue. There's a lot of fatigue outcome measures, but we simply uses a VAS scale in the Dreyer. And we can see that is actually pretty close to what would be seen as consensus for the divider between high to moderate fatigue and low to moderate fatigue. So it turned out that the population's median kind of divided in that, and that was decided a priori, also because we've been doing it in other fatigue analysis, which we have been publishing.
Good, thank you. And I know one of the biostatistician I respect very much says, always look at your data. It's very important because it's so much information is right sitting in front of you that we don't have necessarily going to preconceived notions sometimes for these cutoffs. Last question. So why do you think fatigue is so hard to treat? I mean, your observation, as you said, was disappointing or surprising as the case may be. Why do you think, despite what intuitively I would have thought anti-TNF would make you feel better?
Yes, and it does. I think that's important to say. And one of the findings was also that we actually had some patients that didn't respond in joints, but actually responded well in fatigue. They're just disparate. They're not homogeneous. It's not so you can get a good fatigue response and a bad joints response. So it seems like it's separate entities. We have looked into it with factor analysis and sees that, of course, the main driver of fatigue, which we can explain, is inflammation. So when you treat inflammation, you treat both joints and fatigue. The problem is that we have also identified that some of the fatigue is driven by, we can call it chronicity, having long-standing disease, increasing age, number of failed courses of medicine and so on. So just being, a stressed body with this disease so long. Furthermore, we found, which you could also see, there was a clear association at baseline with fatigue and anxiety and depression, but more so with pain, with chronic widespread pain. It's closely linked to fibromyalgia and chronic widespread pain, which is also very common in these diseases. So part of the fatigue is not from systemic inflammation, it's from, you can call it centralization, so which is quite refractory. And one of the major challenges for us as rheumatologists, because that's part of the residual problem, the unmet need, because we're so good at treating the inflammation to target. At this present point, we're not so good at treating, you could call central manifestations, extra-articular manifestations of disease, which is actually chronic widespread pain and it's chronic fatigue and these central disorders. So I think that's probably part of the reason. But to be honest, we don't really know and we don't understand fatigue in depth at this point.
Sounds like another 5 years or so of research into how to get at this other super important problem with our patients. This is where the disjoint comes. And how can your physician says, you're doing great. And you said, well, yeah, but.
Exactly.
So thank you very much. I really want to thank you, Lars, for expanding on your article, answering all these questions. And I really suggest to our viewers, please read the full-length article entitled Relationship Between Fatigue and ACR Response in Patients with Psoriatic Arthritis Treated with Tumor Necrosis Inhibitor Therapy, a Population-Based Cohort Study by Jørgensen and colleagues, available at jroom.org.
Thank you, Earl. Good to be here.
You. That's fantastic. And to our listeners, we'd love to hear your comments on Twitter or by email. Twitter is @jroom. Email is manuscripts@jroom.com. And I hope to see you all next month in July for my picks. And again, I want to thank Lars Erik Kristensen for taking the time to give us an excellent explanation of his paper and to expand upon it. And I encourage everybody to read this paper. Bye for now.